The Desmin gene. It is the primary intermediate filament found specifically in muscle tissue, skeletal, cardiac, and smooth muscle. It acts as a structural scaffold that keeps the muscle cell organized during the intense physical stress of contraction. The DA gene is located on chromosome 2 at position 2q35, the long arm of chromosome 2. It encodes a protein called desmin. Desmin is a type 3 intermediate filament. In the hierarchy of the cell skeleton, intermediate filaments are between the small actin filaments and the large microtubules. Desmin wraps around the Z-disc, the boundary of the sarcomer, the basic contracting unit of muscle. It connects the Z-discs of adjacent myofibrils to one another, ensuring they contract in unison. It anchors the contractile apparatus sarcomers to the sarcolemma cell membrane and the nucleus. Desmin tethers mitochondria, the energy factories of the cell near the sarcomers, to ensure energy is efficiently delivered where it is needed for contraction. When the DA gene is mutated, the desmin protein becomes defective. This leads to Desminopathy, often referred to as desmin-related myofibrillar myopathy. Pathophysiology: what goes wrong? Toxic aggregates. The mutated desmin protein often fails to form proper filaments. Instead, it misfolds and clumps together, forming intracellular protein aggregates that clumps inside the muscle cells. Z-disc disruption. Because desmin is not supporting the Z-discs properly, the sarcomers become misaligned, often called Z-disc streaming. The result is that muscle cells lose their structural integrity. They weaken and eventually die due to the toxic buildup of protein garbage. Inheritance patterns. Desminopathy is genetic and can be inherited in 3 ways. Autosomal dominant, most common. Only one parent needs to pass down the mutated gene for the child to get the disease. Autosomal recessive, rarer. Both parents must be carriers. This form often presents with a more severe phenotype and earlier onset. De novo, a new mutation occurs spontaneously in the patient with no family history. Clinical presentation. Symptoms. The disease is pleiotropic, meaning it manifests differently in different people, even within the same family. It typically impacts 3 main systems. Skeletal muscle. It usually starts in the distal muscles' lower legs, causing foot drop and difficulty walking. It eventually progresses to proximal muscles, thighs, hips, and the upper body. Unlike Duchenne or other dystrophies, which are purely proximal, Desminopathy often has a distal to proximal progression. As the disease advances, the diaphragm and chest wall muscles may weaken, leading to respiratory insufficiency. Cardiac muscle. The silent killer. Heart involvement is a hallmark of Desminopathy and often precedes skeletal weakness. Cardiomyopathy can present as dilated cardiomyopathy (DCM), restrictive cardiomyopathy (RCM), or arrhythmogenic right ventricular cardiomyopathy (ARVC). The electrical system of the heart is often scarred by desmin aggregates, leading to a V-blocks, heart block, and arrhythmias, which can cause sudden cardiac death. In severe or recessive cases, smooth muscle dysfunction can lead to chronic gastrointestinal issues like swallowing difficulties or intestinal obstruction. Diagnosis is often delayed because the disease mimics other muscular dystrophies. Creatine kinase CK levels are often normal or mildly elevated, unlike Duchenne, where they are massively elevated. A muscle biopsy under a microscope, the stains will show rubbed out fibers, areas where oxidative enzyme activity is missing. Inclusions: red stained clumps on trichrum stain, indicating protein aggregates. Immunostaining: antibodies against desmin will reveal clumps of desmin rather than the normal smooth network. Electron microscopy shows characteristic granulofilamous material at the Z-discs. Genetic testing: sequencing the DA gene to identify the specific mutation, confirms the diagnosis. Treatment and management. There is currently no cure for Desminopathy. Treatment is supportive and focuses on preventing complications, particularly cardiac ones. Cardiac management. This is the most critical aspect. Patients usually require regular monitoring, ECG, Holter. Many will require a pacemaker or ICD implantable cardioverter defibrillator to prevent sudden death from arrhythmia. Heart transplantation may be necessary in end-stage heart failure. Respiratory support. Use of BiPAP, CPAP, or mechanical ventilation if the diaphragm becomes too weak. Physical therapy. To maintain range of motion and manage weakness, canes, walkers, orthotics for foot drop. In summary, the DA gene located in chromosome 2q35 is responsible for the structural integrity of muscle Z discs and links the nucleus and mitochondria to the sarcomere. Key pathology: toxic desmin aggregates form, myofibrils disintegrate. Main symptoms: distal leg weakness, cardiomyopathy, heart failure, block, respiratory failure. Red flags: a patient with muscular dystrophy symptoms who also has heart block arrhythmia. Thanks for watching.